Okay, well, let's go ahead and get started while people are filtering in. I'll talk slowly so that people can join. Um, this morning we have some wonderful teaching residents who are going to be sharing their expertise and knowledge about a potpourri of topics. And so I hope you'll join us in supporting your co-residents by showing your cameras, because I think I'm speaking for many that it's really comforting to have friendly faces to look at instead of a blank screen of names. And so, yeah, if you want to support McKenna and the others, please do turn on your cameras and we will go. And McKenna, I or Devel will watch the chat so you don't have to. You're welcome to yourself if you want to, but that way you can focus on your material. Take it away.
Perfect. I appreciate that. Any help with the chat would be great. Awesome. Hi, everyone. I'm McKenna. I'm one of the R2s in the primary care track and the Clin Ed pathway. Good to see all of you this morning. I am going to be chatting about lower urinary tract symptoms. And my disclosure is that I am not a urologist, so this is purely coming from like the primary care perspective. And so that is my disclosure, and we'll just jump right into it. Also feel free to like put questions in the chat, interrupt me, because this is a complicated topic sometimes. All right. So let me see if I can advance my slides. There we go. So why did I pick this topic? Actually, a few reasons. So the first one is I am like deathly afraid of the PSA test. I hate ordering it. There's like all the questions about screening and like when it's not screening. I never knew what to do after figuring out if a patient had a UTI or not. When I first started making this talk, I had just been at the VA and everyone was on tamsulosin and I didn't know why. And then finally, I saw a lot of this in my clinic patients, and you will too. So 50% of males over the age of 65 and 70% of males over the age of 80 will have lower urinary tract symptoms. So this is like very, very common and something that you will see. So we have 4 learning goals today that I want to make sure we cover. And I really want to start with like a good base and make sure we all have like a shared understanding of what lower urinary tract symptoms are, and then be able to build from there through your clinic visit. So what are you going to do to assess LUTs? How are you going to put it all together in your mind? And then what are you going to do about it? And then when are the important cases where we should get some help from the specialists? Okay. So the first thing that I want to do is just get us all on the same page and figure out what lower urinary tract symptoms are. So like any good doctor, you can type it into Google, and according to Google, lower urinary tract symptoms are a common complaint among men. If you go to Wikipedia, it's a group of clinical symptoms involving the bladder, sphincter, urethra, and the prostate in men. The International Continence Society, which is an organization I didn't know about, said it's symptoms related to the lower urinary tract. And then Up to Date, one of our great resources, says it's nonspecific and any combination of urinary symptoms. So I just want to like recognize that this term is not always specific or helpful, and like we are leading into the land of like vagueness. So I want to just like help us from a urology perspective using their framework, kind of define LUTs and like what are we actually talking about. So the urologist really defined 3 groups of symptoms that all encompass lower urinary tract symptoms. So the first group is those post-voiding symptoms. So things like dribble, incomplete emptying, that's what your patient is going to say to you. The next group is voiding symptoms, so during the stream. So like the classic, oh, are you having any itching or burning, but also straining, hesitancy, slow stream, that type of thing. And then finally, storage symptoms. So having frequency, going at night, incontinence, urgency. Those are the words that your patient is going to use when they're describing the symptoms. Does this make sense to everyone? Everyone kind of understands what we're talking about now? Okay. So we'll jump back into our goals. And so the first part is to summarize a brief differential for LUTs and what can cause these groups of symptoms. So if you could all throw in the chat, what are some causes of lower urinary tract symptoms? BPH, infection, what else? Overactive bladder, Katie, yeah. Gina? Bladder outlet obstruction, Brahm, yes, I agree. What else? Pelvic floor dysfunction, great. Yes, loving all of these answers. And I agree, there's like a ton of different things that can cause lower urinary tracts. I love that BPH was the first one. That's like the most common in this population of patients with a prostate. But there are many, many different things. And so there are really two ways to think about a differential for this. And the first one is going anatomically. And I think that this is helpful for lower urinary tract symptoms because there is very specific anatomy that we're working with. So the first one is causes like within the bladder. So things like cystitis, stone, we said muscle overactivity, bladder cancer can cause this. There's things within the prostate itself. So again, BPH, prostate cancer, prostatitis, things within the urethra. So strictures, other pathology. And then of course, like there's always the like systemic other bucket that you must have when you're thinking about anatomic based differential. So I think this is a good start, but I also don't think that this is all encompassing of the things that can cause lower urinary tract symptoms. So I want to share with you kind of the classic other system based differential as well, because I think it's helpful to kind of have both in our mind. So things that we're thinking about, of course, infection, many people mentioned that in the chat. Lifestyle effects, always important, tobacco, alcohol, drinking a bunch of fluids right before bed can cause nocturia. Medications, we're always doing it to our patients. Metabolic, so very poorly controlled OSA. Diabetes is a classic one that we see all the time, polydipsia. Neoplastic, so we mentioned many of these as well, prostate cancer, bladder cancer. Neurologic things, so spinal cord injury, Parkinson's, MS, we're always screening for those questions. And then of course, like going back to our anatomic based differential, many of our urologic causes, so BPH, stricture, stone. So now that we kind of have in our mind, what are the things that are causing LUTs? I want to give you a targeted framework in order to really assess this in your own patients. And so as you know, the wonderful internist that you are, you're great at all of these aspects of assessing a problem. History, which for our patients would focus on the LUTs symptoms that we talked about, medications, lifestyle factors, chronic diseases. Physical exam, there's many important components, including the DRE, which I'll go into in a minute. And then finally, some validated symptom scores that actually can be helpful in characterizing like the scope of your patient's symptoms. And we'll go into that in a minute later too. Is there anything that I'm missing on this list that you guys can think of? Like history elements that we should be asking about?
McKenna, I'll ask a question. Occasionally, residents will ask me or talk to me family history. Is there any role in which family history has a role in this?
I think it can, particularly from like a malignancy perspective, but I actually think that's less important. I think maybe one of the elements that might be more important than that is like sexual history. Often sometimes something that we don't think about, but like sexually transmitted infections can be a part of this. But that's a good question, John. I don't generally think of family history as like the most important element of this, especially in like the, elderly gentlemen that are in their 80s having lower urinary tract symptoms.
Wes puts in into the chat some questions or comments: trauma history, recent catheter, sex play, etc.
Oh yeah. I really appreciate that, Wes. Yeah, I think there's like many different things that can go into these symptoms that aren't just kind of the common ones that we're talking about, and really important to have a patient-centered approach. Thank you for that. All right, moving along. So this slide should look familiar. Because it's all of the symptoms that we already talked about and the framework that I gave you. But I want to take it to kind of the next level, and I want you to think about these symptoms in a systematic way. And this might be a slight oversimplification, but in general, I want you to think about voiding symptoms kind of together if your patient is having mostly voiding symptoms as BPH. That is very common. And then storage symptoms as overactive bladder. And I do want to say again, this is an oversimplification. Patients often have symptoms from multiple categories. And I also want to recognize that it's like really unsatisfying that the other group of symptoms post voiding does not have like an associated syndrome. There just isn't one, but voiding and storage symptoms kind of together kind of are pathognomonic for BPH and overactive bladder. Okay, moving on to more history taking. So 10% of patients that have LUTS is actually due to medications rather than underlying diseases. And here on the screen is kind of the most common medications that are culprits for lower urinary tract symptoms. And like how many of our patients are on SSRIs? Like very many of them. So if you've recently started or up titrated like one of those medications, think about that if your patient is having new LUTS and maybe adjusting prior to kind of going down the rabbit hole that we'll get to a little bit later. But please take a thorough like med history of your patients because it's not uncommon that medications are the culprit. And I also want to say medications plus BPH like augment symptoms. So if your patient has BPH and is taking one of these meds, their symptoms will be worse. Okay, another part of evaluation, please perform a digital rectal exam. We don't do them enough. There's many ways or reasons why we don't utilize them because we're like uncomfortable with it. We're not trained in it. But it really is the best way to assess the prostate and it will give you a lot of information. I like to share a story of a patient of mine that was having lower urinary tract symptoms for months and didn't want a prostate exam. I didn't really want to do one. But then after a few months, like we did one and he was having exquisite tenderness. We figured out he had prostatitis, treated him with IV antibiotics, and like then he was fine. So if I would have done that exam earlier, like when I was first assessing his lower urinary tract symptoms, I could have saved a lot of months of probably unnecessary antibiotics for UTI and just like a lot of his discomfort with his symptoms. So please do a digital rectal exam. And then the final kind of more novel assessment technique I want you to use is the International Prostate Symptom Score. This is something I previously hadn't heard of, but it's a validated score that has 7 questions, including a quality of life score, and gives you a range of mild, moderate, or severe on how a patient's symptoms are. And so here is kind of what it looks like. It goes through many of those symptoms in those different symptom groups that we talked about. Frequency, urgency, straining, etc., and really gives you an assessment of how impactful the symptoms are. And it's available on MD Calc, which is all of our favorites. So, Javel or John, if you guys could get a poll ready, we're just going to kind of check in on where we're at. So if you have a 70-year-old male with lower urinary tract symptoms in clinic, he's having both voiding and storage symptoms. His rectal exam is normal. His IPSS, prostate score, is moderate, and he smokes 12 cigarettes per day. What do you guys do now? Would you want to do lifestyle counseling? Do you need more information? Do you want to start tamsulosin or refer him off to urology?
McKenna, just so you know, we'll close it when a fair
Perfect.
number of people have answered. I think there's still many people who are waiting to see what their friends say. All right, we'll just end it there.
Perfect. All right, so we have a lot of people that want more information. We have some people that want a lifestyle counsel, and then start tamsulosin. No one wants to refer to urology. Okay, awesome. I agree. So actually there's two right answers. So lifestyle counseling, and we do need a little bit more information to fully assess this patient. So obviously you would want to counsel him to cut down on his tobacco use. And then what more, information do we need? So actually there's 3 simple tests that we can do in clinic that'll give us a lot of information to have a more comprehensive assessment of a patient's LUTs. So the first one is a UA. Everyone knows about this. We look for infection. I'm not going to harp on that. The next test that we can get is a PSA, and this is to evaluate for prostate malignancy. And I really want to stress the point that once the patient is having symptoms, this is a diagnostic test. This is not like the screening for prostate cancer that has not a great USPSTF score and is very confusing. This is a diagnostic test because your patient is having symptoms. So you should get a PSA. All right. The last thing that you should get is a post-void residual. And this really allows you to assess for obstruction and figure out if patient's kidneys are in danger, and kind of rule that out and get that peace of mind. And again, you can do this in clinic. It's not something we always ask for, but you do have the capability to do that. Okay, so here's the 3 tests you're going to order. Because the PSA is so challenging, I just want to take a quick aside and tell you to be thoughtful about interpreting it. As we all know, there's many things that can cause artificially high or low PSA. So some of the things causing a high PSA, BPH, prostate cancer, if your patient's recently ejaculated, if you've done a digital rectal exam, which I just told you to do, it can cause an artificially increased PSA, and then of course infection and inflammation. So just be aware that your test might be elevated for these reasons. On the flip side, your test can also be low. If your patient has obesity, if they've used many different types of medications, including thiazide, statins, NSAIDs constantly. Finasteride is a big one that lowers it, I believe, by almost a point. And then, of course, if they don't have as much prostate tissue from a prior procedure, or they have liver pathology. So again, still order the PSA, but don't just take the value that you get at face value. make sure that you're actually thoughtfully interpreting it. And again, this is a diagnostic, not a screening test. Okay, I'm gonna pause there for questions because we've gone over a lot of information so far.
Lindsay pointed out that there's some really nice pre-printed or pre-made patient instructions in many areas, including UpToDate. And if you look on the patient materials on the after visit summaries that are available. That piece about finasteride is super important. There are some people who will jump right to starting something like finasteride, and you will regret it later when you're trying to interpret your PSA test if you don't get the PSA test first, because you will wonder whether that number is the right number. And so I really do encourage people to get that PSA. If they're going to get the PSA, please do it before you start something like finasteride.
Yeah, I agree. And if we're getting it as part of our initial workup for LUTs, then you'll have it regardless. Great. Okay, I will keep us moving. So we're now kind of moving on to the next part of how do we work with all of this information that we gathered? The history taking, the PSA test, the PVR, our digital rectal exam, like how do we integrate all of this information to figure out what we're doing for our patient? So here's like all of the wonderful information you've gathered. And you can go online and find a wonderful chart like this, or another chart like this that'll try to tell you what to do, or this one that has some red on it and makes you scared, or this other one that just has way too many arrows, or a urology one, or of course, like the classic UpToDate one that's really scary. So I'm gonna make it simple for you. And we're not gonna go searching for all those charts. And here's what you're gonna do. I'm just gonna tell you. So you're gonna do the initial assessment, all the things that we talked about. It's gonna put you into 3 buckets of patients: uncomplicated, likely BPH or complicated LUTs. And then there's some follow-up. And I just want to give you guys the caveat that like this assumes that you've done all of the underlying chronic disease management, lifestyle counseling, medications, your patients like using their CPAP, et cetera, okay? I also want to like hint ahead, there might be some cases, and these might be some of the answers if you wanted to like take a screenshot, so that you kind of know what's coming. But this is like the simple algorithm that we're going to walk through, okay? All right. So we have a 72-year-old male with lower urinary tract symptoms. Your initial assessment that you do says that he's having mostly storage symptoms. His prostate symptom score is 20, which is in the severe category. You do a digital rectal exam, it shows nodularity, and his PSA is 22. Which of those kind of 3 categories do you think this gentleman falls into? You can throw it in the chat. Complicated, great. You guys are so smart. I agree, this is complicated. So the way that I want to have you define complicated is abnormal testing and or red flag symptoms, okay? And the follow-up to complicated is you're going to refer to urology and treat the underlying cause, right? In medicine, we're always like, treat the underlying cause, fix the lifestyle things, but that's what you're going to do. If someone has, abnormal results, that can take a lot of different forms. That could be a UTI on your UA. It could be renal compromise. It could be blood in the urine. It could be neurologic signs. I will get into red flag symptoms later when we talk about when to refer to urology. So I just want you to hold that in your mind. But abnormal testing or red flag symptoms is complicated and you need help. Okay? Simple, right? Okay, let's try again. So we have a 63-year-old gentleman with lower urinary tract symptoms. Your initial assessment shows that he's having both voiding and storage symptoms. His score is a 4, which is mild. He has a completely normal digital rectal exam, UA, and PSA, and he's already on CPAP. So which of the 3 categories does this gentleman fall into?
McKenna, can you name the 3
Oh,
categories?
yeah. Uncomplicated. You guys all got it, right? Complicated, uncomplicated, or likely BPH was the other category. Great. I love it. I see a lot of uncomplicated. And that's absolutely right. So I want you guys to think of uncomplicated LUTS as a normal workup and mild symptoms. Okay. And so what are you going to do for uncomplicated? Well, you're going to reassure your patient and then follow up with them. This is not something that needs any intervention. You could do more harm by, over treating things. Like you're just going to let it ride and do a lot of reassurance that you're not worried about things. You did the workup, and your patient's okay. All right. Okay. Next one. So 68-year-old gentleman with mostly voiding symptoms. His IPSS is moderate. His digital rectal exam is unremarkable. His UA is bland. His PSA is 2.8, which is normal. And his PVR is 110, which is also normal. Which category do you think that this gentleman falls into? BPH, great. I love it. You guys are wonderful at the test skills of process of elimination. Yes, so likely BPH. And the way that I want you guys to think about this category is moderate to severe symptoms on the IPSS and a like relatively normal workup. Okay. The next steps of what you're going to do is you're going to start tamsulosin and follow up his symptoms. To John's point earlier, you could start finasteride. It's like an equivalent medication. But there are like further problems later down the road interpreting that. And I think tamsulosin is like very well tolerated, as is finasteride. I just like to start with tamsulosin, so that's what I'm going to tell you to do, but you do have choice there. I also want to like do the caveat of, we talked about the PSA testing earlier and how it might be slightly elevated in BPH. So if you have a really convincing story and no other like abnormal testing apart from the PSA, it's okay to say that this is likely BPH and repeat the test in like 6 weeks to reevaluate, make sure it's not persistently elevated. I also want to put in a great plug for the urology e-consult. They have been fantastic in helping me interpret like really complicated PSAs where you don't know exactly what's going on and how high is too high, and like just send them an e-consult. They can help you sort it out. But like this PSA should not be markedly elevated. It would just be a little bit elevated. Okay. Great. Here's your summary slide. You're going to assess LUTs, and then there's kind of 3 categories that I want you to, when you're initially evaluating this, put patients into. And again, I just want to like repeat the caveat that you've done all of the medication counseling, you've done all the chronic disease management, and all of the lifestyle effects before you kind of go down this road. Okay. Moving on to the last section. How are we doing on time?
I think you're good. It's 9:30, so
Perfect.
you have time.
All right. So last section is I want to let you all know like when to refer patients to urology. So when exactly we need help with this. And I think going through a specific case is the best way to do this. So we have a 44-year-old gentleman who presents with 5 weeks of lower urinary tract symptoms. He does not appear to have any lifestyle factors contributing. Past medical history, yeah, his tonsils out, otherwise nothing. He takes occasional Tylenol like everyone does. He's adopted, so of course we don't have family history. Sorry, John. Social history, he doesn't use any substances. Sexual history is monogamous with his wife, no sexual dysfunction or symptoms. So kind of a review, what questions, tests, and exam would you obtain to evaluate Mr. C's lower urinary tract symptoms? This is not a trick question. We went over it already. Love it. Rectal exam, UA, PVR, IPSS, PSA, UA. Love it. Ah, you guys are amazing. Yes, all of the above. Here's your answers. So symptoms, storage and voiding symptoms, IPSS of 24. Digital rectal exam has nodularity. Abdominal exam is unremarkable. PSA is 12. PVR is normal. UA has RBCs and is otherwise negative. All right, what is concerning to you guys, if anything? Nodularity, RBCs, elevated SPA. I think you meant PSA, but I love it. We can go to the SPA maybe later. Yes. Anything else sticking out? Age, yes, Noga. I agree. This is like a young man. This is not normal, right? There's a lot about this that is concerning. And what is it that you guys are concerned about? Just to like put it out there. I think a lot of people are thinking it. Cancer, yes, yes. I am worried about cancer in this person. We just talked about the red flag symptoms. So here, just like very explicitly are the red flag symptoms when I want you to like absolutely refer to urology and get more help. So the first one is like, again, we talked about this, that wildly abnormal PSA, digital rectal exam that's like very nodular, that is not that nice smooth prostate. Age less than 45, lower urinary tract symptoms less than age 45 is very atypical, and like that in and of itself, you should refer to urology. Blood in the urine, again, not normal. I think we all know that. Any evidence of renal damage or urinary obstruction? I personally have seen this more in like the inpatient setting, right? When you're calling down to get like nephrostomy tubes because you're worried about renal compromise, but you can see it in the outpatient setting too. Definitely get some help. Recurrent or treatment-resistant infection. If you have like treated someone for prostatitis multiple times and it's still not responding, urology might be able to help you. ID is the other specialty that might be able to lend some assistance here. I think this next section is very obvious. If someone has had a urologic cancer or like pelvic radiation and they're still having symptoms, like that is definitely an appropriate specialty management person. Like their anatomy is weird, like it is outside of our wheelhouse in primary care. Neurologic cause of symptoms, definitely refer to urology. And the reason for this one is mostly that you might need to plan for like a chronic Foley or self-cathing. And so that really like involves our specialty support for that. And then finally, like an adult that is wetting the bed or having like only nighttime symptoms, especially if you've like evaluated them for OSA. Excuse me. That is pretty atypical. And so that is something that you should send to urology to get some more help for, because not normal. All right, so these are the situations in which you're going to get some help. So we'll just kind of sum up our case. Mr. C, you're obviously concerned about prostate cancer. Up-to-date search tells you that 10% of new diagnoses of prostate cancer can occur in men younger than age 55. I was really surprised by that. So you send him to urology urgently to get evaluated. All right. I have a few take-home points for all of you. First one is when you see someone on your schedule with lower urinary tract symptoms, have kind of a differential in mind, whether you use that anatomic differential or a systems-based differential. Think about all of the different causes, including things like medications, chronic diseases, lifestyle effects that could be contributing. Next, you guys are getting really good at this. You're going to evaluate with your 3 symptoms groups: storage, voiding, and then post-voiding. You're going to do a digital rectal exam. You're going to use the IPSS on MD Calc to assess kind of where your patient's at. And then you're going to get those 3 simple tests in clinic and interpret the PSA with caution. The next thing you're going to do is think about those 3 groups and that simplified algorithm that we talked about. Complicated, which is abnormal workup or red flag symptoms, you're going to get help. Uncomplicated, which is mild symptoms, normal workup, you're going to reassure your patient. And then likely BPH, in which case you're going to likely start tamsulosin. And then finally, you're going to get some help from our specialists when you have red flag symptoms or patients don't improve with treatment, or use an e-consult if you don't know how to interpret the PSA. That is all within acceptable practice for PCPs. That's all I got. What questions do you have?
What are your thoughts about Tamsulosin doses 0.4 milligrams versus 0.8? I feel that urology tends to increase the dose if the symptoms aren't improved on the first line. Is this within the PCP's scope?
Yeah, absolutely. It's within scope. And that's generally my practice as well, is I'll start someone on the lower dose and follow up in, a month or so. And if it's not working, then I'll increase the dose. And then even if that's not working, sometimes I'll think about adding a second agent like finasteride. And making sure that, symptoms haven't gotten worse or changed, or new red flag symptoms haven't popped up during that time. I also think that that's a good situation in which the IPSS is actually very helpful, because you can kind of track over time if your patient's symptoms are improving. So even if they still say, oh, I have symptoms, you can say, oh, well, last time you scored a 17 on this test and now you're scoring a 13, kind of like how we use the PHQ-9. And then you can, escalate therapy or make, a decision with your patient. But definitely like within the scope of a PCP.
While people are putting in other questions, you may have said this and maybe I just missed it. You've referenced OSA a couple of times. Do you mind sharing your thoughts of why is OSA treatment important in all of this?
Yeah. Gosh, you're gonna test my like pathophysiology, which I'm not going to like poorly share, but voiding at
Broad strokes.
voiding at night is one of the predominant like symptom features of uncontrolled OSA. And so if you have a patient that is having a lot of like nighttime urination and like hypertension, like look for OSA, because patients will like stop breathing, right? Wake up, not really realizing it, then like go to the bathroom because they're like have been woken up from their OSA. And so it's like not uncommon that they'll actually, come in complaining of urinary symptoms when actually they have OSA. That was not a very eloquent description. I think
Uh,
you get the gist.
yeah, no, that's very helpful.
Oh, there's a podcast. Thanks, Wes.
Lindsay says, I'm on sleep medicine right now, and I heard an attending say the nocturnal OSA is also related to cortisol associated with arousals.
Oh, I don't know about that, but I believe it.
Yeah. And I think that to your point that oftentimes people awake and they aren't aware of why they awoke and they say to themselves or think to themselves, maybe I just need to go to the bathroom. And so sometimes it's a little bit of like two things being associated when they're not necessarily associated too.
Yeah.
Fantastic. Other questions? Wonderful. McKenna, as always, I learned so much when you give us a talk or share your knowledge. We are going to take a break in a moment, and appreciation coming through. But before we break, I'm actually going to ask Sayuli to maybe turn on her camera and unmute herself and say a few words about next week's academic half day. There's an email that went out, and some of you who participated last year remember this, and some of you who weren't involved may not know exactly what we're talking about. So, Sayuli, can you say a few words?